Oh, thanks very much, Dr. Gleave. An interesting topic and one that I've kind of gotten involved with early on in my residency training with a project with Dr. Black and some others in the department here. So for those of you who don't know me, I'm John Suderman, one of the PGY3 residents here at UBC Urology. Last year, I did my grand rounds on Lynch syndrome in urology, and I found it to be a very interesting topic, but was certainly very niche in its daily applicability. This year, I wanted to present on a topic that was a little bit more tangible to the everyday urologist while still highlighting some exciting new advances in the field. So with that, I'll talk about active surveillance in prostate cancer. I'll start with a quick overview of my presentation. I'll follow a brief clinical context and history of how active surveillance came to be, along with a review of prostate cancer detection. I'll move on to speaking about the introduction of active surveillance in prostate cancer, along with both the strengths and pitfalls of using clinical criteria to choose those eligible for surveillance. Next, I'll discuss advances in the field with new imaging technologies, novel biomarkers, and the use of artificial intelligence to better understand the disease and its progression, which are all used to hone our selection criteria. Starting with the discovery of PSA, in the early 1960s and 70s, researchers looked for tumor-specific antigens, which might be useful as targets for new cancer therapies. Experiments at the time typically involved injecting an extract of human tissue into rabbits, then testing the rabbit serum for antibodies. In a landmark study in 1979, Wang purified PSA and suggested it might be used as a biomarker for prostate cancer. This set the stage for the development of a PSA blood test, which was achieved a year later by Papsidero and Kuriyama. They developed a sensitive ELISA immunoassay and performed early studies exploring clinical uses of PSA as a biomarker in prostatic diseases. Ultimately, Ti-Ming Chu at Roswell Park Memorial Institute received the patent for the discovery of purified human prostate antigen in 1984, and Chu can be seen pictured here. Chu's work was validated in part by Thomas Stamey, and PSA was found to be useful in monitoring the disease course in patients with known prostate cancer. As we all know now, they noted elevated PSA levels in other pathologies such as BPH or prostatitis. Further, they noted that PSA was sometimes low or normal in patients with prostate cancer, and PSA was not believed useful as a first-line screening test. Therefore, PSA was largely used for monitoring the response of prostate cancer to treatment. In the early 1990s, it was demonstrated that PSA could be used as a first-line screening test for prostate cancer, and this led to the approval of PSA by the US FDA to be used in early detection of the disease. PSA derivatives like PSA velocity, density, and free to total PSA ratio further improved the accuracy of PSA testing. Despite what they're teaching in medical schools these days, we all know that PSA isn't all bad. During the so-called PSA era throughout the 1990s, the number of patients with advanced disease at diagnosis decreased by 80%, and the age-adjusted prostate cancer mortality rate decreased by around 40%. Statistical modeling studies completed by the Fred Hutchinson Cancer Research Center and the University of Michigan estimated that 45 to 70% of this mortality decrease could be directly attributed to PSA screening. On the flip side, PSA screening during that era led to overdiagnosis and subsequent overtreatment of patients with low-risk disease. The graph shows the dramatic spike in American prostate cancer incidence from 1992 to 1993, shortly after the approval of PSA screening in 1991. Over time, research emerged showing that low-risk prostate cancer allowed for active surveillance of the disease. Active surveillance strategies and criteria were therefore developed. No doubt, active surveillance uptake has increased over time. Mahal published data from across the US in 2019 showing treatment trends in low, intermediate, and high-risk disease between 2010 and 2015. The data reports active surveillance and watchful waiting together in a single group, showing an increase from 14 to 42% in these management strategies over that time for low-risk disease. There was a slight increase in uptake for intermediate risk disease and no significant change for high-risk disease. The Canadian Partnership Against Cancer came out with a report in 2015 specific to Canadian patients and practices. These results were comparable to the US data just shown. This graph shows the percentage of low-risk prostate cancer treated with different modalities, with approximately 50% managed with active surveillance. Even if thought to be low, the risk of prostate cancer progression, metastasis development, and ultimately prostate cancer-specific mortality is never zero. Therefore, selecting the right patients for surveillance is extremely important. The first definition of clinically insignificant prostate cancer was published back in 1994 by Jonathan Epstein, and criteria included clinical stage T1C or less, PSA density less than 0.15, Gleason score less than or equal to 6, less than 3 positive prostate biopsy cores, and less than 50% cancer per core. These criteria have been validated in large cohorts in which reported prostate cancer mortality ranged from 0.02% at 4.5 years to 5% at a median of 15 years. Over time, multiple studies have shown about a 73 to 76% efficacy for Epstein criteria in identifying clinically insignificant prostate cancer in comparison to pathology on prostatectomy specimen. Nowadays, active surveillance criteria exist. Many active surveillance criteria exist, all varying slightly based on histopathology, clinical T-stage, and PSA parameters. This table is meant to show just how many different active surveillance criteria currently are out there. Notable groups that have developed their own criteria include UCSF, Memorial Sloan Kettering, and the National Comprehensive Cancer Network, or the NCCN. The cutoffs vary slightly between institutions. Johns Hopkins applies the most stringent criteria based on the Epstein criteria, and the Royal Marsden Group applies the most relaxed. Studies have shown the varying criteria largely have similar performance to the Epstein criteria. Concordance data has been published by multiple groups. Pathology data was analyzed for 360 men in the Prius cohort receiving radical prostatectomy after discontinuing active surveillance. For men who switched to radical prostatectomy due to anxiety, 57% had a favorable pathologic outcome, 26% had an intermediate pathologic outcome, and 17% had an unfavorable pathologic outcome. Altogether, 43% of patients were either upgraded or upstaged. Dr. Klotz and the group in Toronto have a large cohort of patients managed on active surveillance. They carry a liberal approach, including all low-risk disease, and selected intermediate-risk patients with Gleason 3+4 disease or PSA greater than 10. Their published 15-year prostate cancer-specific mortality was 1.5% in 2015. They found that most of the metastatic cases were Gleason 7 at diagnosis. The hazard ratio for metastasis at 15 years was 3.75 times greater for intermediate compared to low-risk disease. Gleason 7 patients were at particular risk, as 20% had metastatic disease at 15 years. Importantly, PSA greater than 10 had very little correlation with likelihood of metastatic disease. As previously mentioned, the Hopkins group was more restrictive, offering surveillance only to patients who fulfilled the Epstein criteria. The benefit was a prostate cancer mortality rate of 0.5% at 15 years. However, the downside was that only 20% of newly diagnosed patients were eligible versus 50% in the Toronto cohort. This in part led to an iteration of the NCCN guidelines, defining the original Epstein criteria as very low risk prostate cancer. The terminology has evolved, but the point was to aid urologists in adopting active surveillance, not only in the very low risk group, but also in the broader low risk setting. Those familiar with the NCCN criteria know that there's a defined difference in favorable and unfavorable intermediate risk prostate cancer. These groups were originally identified by Zoomstig out of Memorial Sloan Kettering in 2013. Unfavorable intermediate risk prostate cancer was defined as having any intermediate risk patient with a primary Gleason pattern of 4, positive biopsy percentage greater than 50 by cores involved, or multiple intermediate risk factors, including T2B or C disease, PSA between 10 and 20, or a Gleason score of 7. The rest were considered favorable intermediate risk. You can see in the figure a comparison of favorable and unfavorable intermediate risk patients undergoing dose-escalated external beam radiotherapy. Graph A in the top left compares PSA recurrence-free survival. B shows local failure, C shows distant metastasis, and D shows prostate cancer-specific mortality. Visually, you can see the groups carry distinct clinical courses, and all showed a statistically significant difference towards the favorable intermediate risk category. This led to the changes in the NCCN guideline that I already alluded to, allowing active surveillance to be considered in favorable intermediate risk disease. This includes Gleason 3+4 in the absence of other risk factors. Despite the increased risk of adverse pathology, increased chance of metastatic disease, and lower survival for intermediate risk disease shown previously, use of active surveillance or watchful waiting in intermediate risk prostate cancer has increased from 5 to 10% from 2010 to 2015. Data emerged 1 year later directly comparing long-term active surveillance data between those with intermediate risk and low-risk disease. Munsanuru found that those with intermediate risk disease had lower 15-year cause-specific survival than those with low-risk disease, and questioned the routine use of active surveillance among intermediate risk men. The figure compares the low-risk and intermediate risk groups, figure A showing 15-year overall survival, B shows cause-specific survival, C shows metastasis-free survival, and D shows the probability of remaining on active surveillance. Results from the last few slides together lead to a marginal gray zone in what defines clinically insignificant disease using clinical markers alone, complicating eligibility criteria for active surveillance. The Vancouver Prostate Center published similar data, including 651 men with low and intermediate risk prostate cancer, managed initially with active surveillance. During the median follow-up of 4.5 years, 40% underwent definitive treatment. Treatment rates were no different between the NCCN low risk and intermediate risk groups shown in the left-hand figure, but were higher for CAPRA intermediate risk compared to CAPRA low risk groups. NCCN unfavorable intermediate risk patients had a 2-fold increased risk of definitive intervention compared to favorable intermediate risk patients, shown in the right-hand figure. Overall, independent predictors of active surveillance cessation included percentage of biopsy cores positive and Gleason grade group 2 or higher on initial diagnosis. Pathologic features other than just Gleason score have been studied. The figure shown here shows Gleason 4 patterns and intraductal carcinoma. Photo A in the top left shows fused glands, B shows ill-defined glands, C shows cribiform glands, D shows a glomeruloid gland, E shows intraductal carcinoma, and F shows the presence of basal cells on immunohistochemistry. Queldom showed that after treatment, patients with Gleason grade group 2 disease without cribiform or intraductal carcinoma had similar biochemical recurrence-free survival compared to those with Gleason grade group 1 disease. Biochemical recurrence was 20% for grade group 1, 21% for grade group 2 without cribiform or introductal features, and jumped to 41% for grade group 2 with cribiform or introductal features. Cribiform pattern alone is a strong predictor of distant metastasis and disease-specific death. Further, the overall survival in patients with cribiform pattern was shorter than in patients without. This study suggests that patients who have cribiform architecture or introductal carcinoma may not be good candidates for active surveillance, although to date, no studies have specifically investigated the impact of cribiform glands in a prospective active surveillance population. Swinging back to the study out of Toronto in 2015, we've already discussed overall cancer-specific outcomes, including a very low rate of metastatic and cause-specific mortality in their active surveillance cohort. All things considered, a prostate cancer-specific mortality of 1.5% is quite a remarkable outcome and proves the utility of active surveillance regimens. This is in comparison to an actuarial cause-specific survival of 94% at 15 years. Certainly, active surveillance for favorable risk prostate cancer is feasible and seems safe within the proven 15-year timeframe. However, at 15 years, 45% of patients on those protocols underwent treatment or were taken off active surveillance protocol. So it's this discrepancy that keeps pushing research in the area forward. And we know that our initial selection of patients can be improved upon by as much as 45% at 15 years. A major limitation to the data presented so far is that the diagnosed disease on biopsy is often discordant from its surgical pathology. Prostate cancer tissue diagnosis is made by transrectal or transperineal biopsy. Standard template transrectal sextant biopsies were used in the initial evaluation of many active surveillance protocols, including the Epstein criteria introduced way back in 1994. Risk of missing high-grade disease is related to the volume of tissue biopsied. Ploussard therefore studied different biopsy templates in prostate cancer detection using sextant, 12-core, and 21-core biopsies. Prostate cancer detection rates were 32%, 40%, and 43% respectively. Substratification revealed the 21-core protocol was better in patients with prostate volumes greater than 70 grams, in men with PSAs less than 4, and in those with a PSA density less than 0.2 nanograms per milliliter per gram. This suggests men with large glands or with small lesions may benefit from a greater volume of tissue being sampled. A modified Epstein criteria was studied by Krivenko in 2014. They replaced the sextant template with a 12-core template and modified the criteria by replacing the 50% maximum percentage core criterion with a requirement that all positive cores be unilateral. Both original and modified criteria resulted in similar rates of misclassification. The interesting part of this study was that in white men, this misclassification was demonstrated in 27% compared to 51% in African American men. This is likely secondary to a greater frequency of anterior tumors seen in African American men at 44% versus 28% in white men. These results highlight the importance of improving diagnosis, especially in certain higher risk patient populations. Thankfully, over the last 10 years, multiparametric MRI has been shown to reduce misclassification of disease. Over this time, the goals in prostate cancer diagnosis have shifted from merely identifying cancer towards limiting detection to only clinically significant disease if it is present. Multiparametric MRI combines information from T1 and T2 weighted images along with functional information from dynamic contrast enhanced and diffusion weighted imaging. This modality has been shown to increase our ability to target lesions on biopsy. Starting with T2 weighted images, these are the most useful in defining zonal architecture of the prostate. The peripheral zone appears homogeneous due to high glandular ductal tissue content. Prostate cancer generally has high cellularity and low water content and will appear hypointense on T2 weighted images. Notably, a decrease in intensity has been shown to correlate with the aggressiveness of prostate cancer. The transition zone, on the other hand, has a higher cellular density and appears heterogeneously hypointense. This makes cancer detection more challenging based on T2 imaging. T2 lesions can be difficult to interpret as acute or chronic prostatitis, scars, irradiation, hormone treatment, and post-biopsy hemorrhage can mimic prostate cancer. T1 weighted images provide limited value in detecting prostate cancer. T1 images can detect biopsy-related hemorrhage, which may obscure or mimic disease. Generally, it's recommended that MRI be deferred at least 6 to 8 weeks post-biopsy to reduce biopsy artifact. The image in the slide shows a lesion in the left peripheral zone at the prostatic base. The lesion is hypointense on T2 weighted imaging. Next, we have diffusion weighted imaging. This sequence shows random movement of water within prostate tissue. Acquisition of at least 2 B values allows the calculation of apparent diffusion coefficient, or ADC maps. In areas with densely packed tumor cells, diffusion is impeded, appearing bright on diffusion weighted MR and darker on the ADC map. The image shows further sequences of the same prostate from the previous slide. The top right shows restricted diffusion on diffusion weighted imaging, and the suspicious lesion appears hyperintense. The bottom left shows the corresponding hypointense signal on ADC map. T2 plus diffusion weighted imaging results in higher sensitivity and specificity in detecting prostate cancer compared to T2 weighted images alone. Last, we have dynamic contrast enhancement. These images look for tumor angiogenesis by evaluating velocities and intensities of contrast uptake and washout. Early enhancement is a hallmark of prostate cancer. The diffusion contrast enhancement sequence assesses tumor angiogenesis. A gadolinium contrast agent is injected and T2 weighted images are rapidly generated. This modality allows evaluation of both the intensity and the dynamics of contrast enhancement. Early enhancement is a hallmark feature of cancer. Looking back at our figure, the bottom right portion of the image shows early enhancement of the lesion compared to the rest of the gland. With all that in mind, the Prostate Imaging Reporting and Data System, or PIRAD scoring system, was designed in order to standardize diagnostic findings. It was first introduced in 2012, and an updated version came out in 2015. Scoring is mainly based on T2 weighted imaging for the transition zone and diffusion weighted imaging and ADC map for the peripheral zone. Peripheral zone lesions can be upgraded by positive findings on dynamic contrast enhancement. Similarly, a high diffusion weighted imaging score can upgrade transition zone lesions. A few landmark studies that I'd be amiss to leave out include the PROMIS, Precision, and Precise trials. The PROMIS trial set out to identify men who could safely avoid prostate biopsy and the proportion of clinically significant prostate cancer correctly identified by multiparametric MRI. All men included were biopsy naive. They found that for identification of clinically significant disease, multiparametric MRI had a greater sensitivity than systematic trus biopsy relative to the gold standard of transperineal biopsy. With a positive predictive value of only 51%, not all patients with lesions on MRI had prostate cancer. However, the negative predictive value was quite good at 89%. Based on these findings, the researchers suggested that use of multiparametric MRI likely allows 27% of patients to avoid a primary biopsy, with an associated 5% reduction in the diagnosis of clinically insignificant prostate cancers. The PRECISION trial tested MRI targeted against a standard trust biopsy in detecting clinically significant disease. 500 men were randomized to either MRI targeted biopsy or standard trust biopsy. 28% of men had MRI results that were not suggestive of prostate cancer, so they did not undergo a biopsy. Clinically significant cancer was detected in 38% of the MRI targeted group, compared to 28% in the trust group. Further, a few men in the MRI targeted biopsy group were diagnosed with clinically insignificant cancer with an adjusted difference of 13%. The findings confirmed that multiparametric MRI targeted biopsy could detect more cases of clinically significant disease, limit detection of clinically insignificant disease, all while allowing 28% to avoid biopsy altogether. An additional piece to the MRI targeted biopsy puzzle comes from the PRECISE trial. This study was designed independently, but in coordination with the PRECISION trial. Participants included biopsy-naive men with a clinical suspicion of prostate cancer. Men were randomized to either MRI targeted biopsy or 12-course systematic trust biopsy. Men in the MRI group underwent biopsy only if a PIRADS 3 or greater lesion was identified. 37% of men had a negative MRI and avoided biopsy altogether. Clinically significant disease was identified in 30% of men in the trust group versus 35% in the MRI targeted biopsy group. Clinically insignificant cancer detection was again reduced in the MRI arm. These findings, paired with those of the PROMIS and PRECISION trial, support a growing body of evidence that multiparametric MRI should be used as a triage test to separate clinically insignificant and clinically significant prostate cancer at initial diagnosis. No doubt, targeted biopsy provides a route to better select patients for active surveillance at diagnosis. In the setting of confirmatory biopsy for patients on surveillance with no prior MRIs, PASOA found that targeted biopsy of PIRADS 3, 4, or 5 lesions led to reclassification of 9, 75, and 100% of patients respectively. Zai's meta-analysis reported similar findings from 5 studies combining for 834 patients. PIRADS 4 and 5 lesions had a positive predictive value of 72% and diagnostic odds ratio of 6 for adverse pathology at prostatectomy. Their analysis suggested that patients with PIRADS 4 or 5 lesions might be unsuitable for monitoring on active surveillance. So how can we now integrate targeted biopsy results into conventional criteria for active surveillance? The MRI and active surveillance group reported results for 100 men with low risk or low volume grade group 2 disease. They all underwent multiparametric MRI and saturation biopsy at baseline. Annual prostate MRIs were carried out with repeat biopsy only triggered by progression on imaging, an increase in PSA density, or at the 3-year study endpoint. 44% of men with positive surveillance multiparametric MRI findings were reclassified versus 11% based on the end of study biopsy with negative surveillance imaging. Using MRI results as a trigger for evaluation, biopsies were avoided for 3 years in 71% of men. The image shows that participants with persistently suspicious multiparametric MRI results had high rates of progression at 83%, while those who had negative surveillance imaging had a much lower rate of progression at 12%. Looking further into MRI use in active surveillance protocols, additional data was reported by the active surveillance cohort in Toronto. The ASSIST study randomly assigned patients with grade group 1 prostate cancer to either multiparametric MRI or no MRI before confirmatory biopsy. A similar proportion of patients were able to continue active surveillance in each group. However, men receiving multiparametric MRI had fewer active surveillance failures and fewer clinically significant cancers at 2 years. The results of this study were perhaps not as strong as anticipated. This is thought to be secondary to inexperience with MRI and fusion biopsy in 2 of the 3 sites. The idea of replacing biopsy with MRI is, of course, a critical one, but still an unanswered question. Many are already doing it, but we don't really know exactly how safe it is. The evidence quite clearly suggests that baseline use of multiparametric MRI helps detect clinically significant disease while limiting insignificant disease. It is also likely useful in the surveillance setting, allowing men to avoid numerous repeat biopsies and their associated risks. MRI findings might also aid in the definition of clinically insignificant disease, but to my knowledge, this has not yet been written into any well-used guideline. In fact, the AUA guideline states that in patients selecting active surveillance, clinicians should utilize multiparametric MRI to augment risk stratification, but this should not replace periodic surveillance biopsy. Despite its growing uptake, even in our clinics here at UBC, standard protocol has not been established and no single strategy has been used to prompt definitive therapy with regard to MRI findings. As we've previously discussed, PSA is fundamental in screening, diagnosing, and following the disease course of prostate cancer. It is, however, not without its limitations and is still not a specific biomarker for prostate cancer. Therefore, research continues to identify new biomarkers in the form of urine, blood, and tissue-based tests, along with development of artificial intelligence technology at the time of diagnostic biopsy. Isoforms of PSA have been identified and studied. The Prostate Health Index uses P2-PSA, free PSA, and total PSA to calculate a prostate health index score. This value has been approved as a biomarker in prostate cancer to prompt biopsy. The Prostate Health Index is calculated by dividing P2-PSA by free PSA, then multiplying this ratio by the square root of total PSA. Intuitively, this formula makes sense in that men with a higher total PSA and P2-PSA with a lower free PSA are more likely to have clinically significant prostate cancer. Houlgat assessed the specificity of the Prostate Health Index. At a sensitivity of 95%, the specificity for clinically significant prostate cancer was 36%. This in comparison to 17 and 19% for total and free PSA independently. They report a prostate health index cutoff of 24 to avoid 41% of unnecessary biopsies. Fossati showed that the prostate health index was a significant predictor of adverse pathology outcomes, including PT3 disease or pathology showing grade group 2 disease or greater. However, the prostate health index was not shown to result in a greater net benefit to the patient in decision curve analysis. PHI and multiparametric MRI were combined in a study of 253 men from the Johns Hopkins active surveillance cohort. Schwen reported that PHI and PHI density were predictive of grade reclassification to grade group greater than or equal to 2. The combination of PHI and multiparametric MRI led to grade reclassification negative predictive value of 98%, and a clinical trade-off of avoiding 20% of biopsies at the cost of missing only 2.6% of grade reclassifications. This was, however, a retrospective study carrying the associated limitations of selection bias. The 4K score is calculated from a panel of 4 kallikrein protein biomarkers: total PSA, free PSA, intact PSA, and human kallikrein-related peptidase 2, together with the patient's clinical history, including their age, DRE findings, and biopsy history. Overexpression of PSA and HK2 kallikreins alter cell growth regulation and increase extracellular matrix degradation, promoting cell invasion and angiogenesis. These can contribute to prostate cancer progression and metastasis. The markers are entered into a model that calculates the risk of finding high-grade prostate cancer on biopsy. PEREC ran a multi-institutional prospective trial evaluating the 4K score compared with standard of care biopsy results. They found that using the 4K score to select patients to biopsy might decrease the number of biopsies performed by 30 to 58%, the cost of which would be delaying diagnosis in about 1 to 4% of patients with grade group greater than or equal to 2 disease. Lin used the Canary Pass database, a database to which UBC contributes patients, to investigate whether the 4K score improves prediction of prostate cancers over total PSA and age alone. The 4K scores were calculated before the first and subsequent surveillance biopsies in order to predict the presence of intermediate risk disease in 718 men on active surveillance. They found that the 4K panel was significantly associated with reclassification at the first surveillance biopsy, but provided no benefit at subsequent biopsies. Tumor genetics might also help to predict disease progression. PTEN loss can have an impact in regulating cancer biology. The image shows a schematic of the PTEN PIP3 pathway. PIP3 binds to and activates downstream proteins, including PDK1 and AKT. These in turn regulate processes including cell cycle progression, apoptosis, cellular growth and translation, angiogenesis, and activation of the mTOR pathway. PTEN negatively regulates this pathway. In this sense, PTEN is a tumor suppressor gene. PTEN has been found to be inactivated in 18 to 24% of prostate cancer, and PTEN loss has been associated with adverse pathologic features on surgical pathology, including both grade group greater than or equal to 2 and advanced pathologic stage. It is also associated with shortened time to recurrence, disease-specific survival after surgery, and in castration resistance. In 2 studies specific to patients already on active surveillance, PTEN loss was more frequent among those who experienced reclassification or progression. In the Johns Hopkins cohort, PTEN loss was present in 1.5% of patients who did not undergo biopsy reclassification versus 9% of patients who did. In Prius, PTEN loss was associated with a higher risk of disease progression and adverse radical prostatectomy findings. With regard to germline mutations, we know that men with BRCA1 and 2 mutations have a higher risk of developing prostate cancer. But does their disease course differ than those without? Castro has shown that prostate cancer with germline BRCA1 and 2 mutations were more frequently associated with Gleason greater than or equal to 8 disease, T3 or T4 staging, nodal involvement, and metastasis at diagnosis. Cause-specific survival was significantly longer in non-carriers compared to carriers. In localized prostate cancer, the 5-year cause-specific survival and metastasis-free survival were significantly shorter in BRCA2 carriers than in non-carriers. The question of active surveillance in patients with BRCA mutations is certainly an important one. No specific active surveillance regimen is defined in this space, but I think most urologists would have a pretty low threshold to treat these patients. Notable genomic tests include PROLARIS, ONCOTYPEDX, genomic prostate score, and DECIPHER. PROLARIS measures expression of 31 cell cycle progression genes to obtain a score that predicts prostate cancer progression and mortality. COL studied 547 patients with low cell cycle progression scores on active surveillance and found a low rate of adverse events at a median of 2.2 years. Unfortunately, there's a paucity of data in patients with high PROLARIS scores in the active surveillance setting. The 17-gene ONCOTYPEDX genomic prostate score selects genes related to disease recurrence after radical prostatectomy or adverse pathology at biopsy. A 2020 study from the Canary Pass cohort reported that the genomic prostate score was not significantly associated with upgrading of disease on surveillance biopsy or adverse pathology. Therefore, the genomic prostate score likely does not add much value in the active surveillance setting. DECIPHER is a genomic test that uses the expression of 22 RNA markers to predict metastasis and prostate cancer specific mortality after radical prostatectomy and is likely the best genomic test on the market. Hurliman studied men with favorable intermediate risk disease who underwent prostatectomy. DECIPHER results were an independent predictor of adverse path. They found that patients with favorable intermediate risk prostate cancer and a low DECIPHER score had similar rates of adverse path to those with low risk disease. This shows that DECIPHER is able to stratify men with favorable intermediate risk prostate cancer, an area of ambiguity from our previous discussion. Biomarkers continue to emerge, and processing the data and integrating it into practice is a little bit like drinking water from a hose. Data appears promising for some options, but local availability and cost for each of these tests plays a factor in clinical integration. A major limitation to many of those novel biomarkers is that they lack long-term evidence at this point in time. Finally, artificial intelligence has shown promise in assisting radiologic and pathologic analysis of prostate cancer. Machine learning methods can be used in genomic studies to identify genes or groups of genes to predict whether a clinical outcome is high. Schomburg built a model detecting SPOT mutations in prostate cancer using only digitized H&E stained slides from prostate biopsy. They used a cohort of approximately 170 prostate cancer patients from the Cancer Genome Atlas to train the model, then validated the model against 150 patients from the MSK Impact cohort. Mutants and non-mutants were accurately distinguished and shown to be robust on different section types. This model was the first of its kind to be able to predict a genetic mutation in cancer directly from the patient's digital H&E microscopy slide. The figure shows how a whole slide image is split into patches at low magnification. Important patches are identified usually by a pathologist. The patch with the most cancer cells is deemed the dominant tumor patch and further analyzed. At high magnification, a sliding window within the dominant tumor patch shows the region with maximum abnormal cells, and deep neural networks then predict the SPOT mutation. We continue to identify more molecular features of clinical relevance. Cather recognized that genetic changes in tumor cells can influence the tumor microenvironment, resulting in genotype-phenotype correlations on digitized whole slide images. In Cather's analysis of prostate cancer, their deep learning system was able to detect TP53 and FOXA1 mutations directly from histologic sample. They displayed similar findings in detecting genetic changes on pathology analysis in lung, colorectal, and gastric cancers, among others. Deep learning-based prostate cancer models have been developed that link histopathology not only to genetic mutations, but also directly to patient outcomes. For example, time to PSA recurrence after radical prostatectomy. Here at UBC, Dr. Bashashadi's deep learning model has identified 2 independent risk groups shown on Kaplan-Meier curves. 150 patients, 95 with grade group 1 and 55 with grade group 2 disease who were eligible for active surveillance, were included in this analysis. The model identified an independent high-risk group that would likely benefit from treatment over surveillance. There were no statistically significant associations between grade group and the groups identified by the algorithm. This suggests that the machine learning model identified novel histopathology patterns for risk stratification beyond just Gleason grade group grades. This may well represent the next era in active surveillance selection, where we were able to move on from conventional criteria altogether and confidently select patients for treatment versus conservative management directly at the time of diagnosis. So in summary, I hope I've given a nice overview of where we've come from and where we were going in the realm of active surveillance. I think there are promising new technologies in development, which will continue to add confidence in our selection of men to manage conservatively or treat radically. Special thanks to Dr. Black for reviewing my slides prior to my presentation today. And with that, I'll open the floor for discussion.